Please welcome Dr. Jim Hornstein.
Ladies and gentlemen, good evening. Welcome to actually our third Ethics in Healthcare series hosted by the Community Memorial Hospital Healthcare System. My name, as Mike said, is Dr. Jim Hornstein. I am the chairman of Community's Healthcare Ethics Committee, and really it's my great honor and privilege to moderate tonight's highly important topic of caring for our aging parents and also for our loved ones. Thank you all, first of all, for coming so much to our evening tonight. Before I begin, I hope you don't mind, I'd like to ask a few questions just to get a feel for who's in the audience tonight. Firstly, if you wouldn't mind by raising your hands, how many here tonight is currently aging? Don't be shy, we're all among friends. To those of you who are watching, we're videotaping this, the answer is 100%. And that's actually a good thing, frankly, because if you're not actively aging, well, the alternative is not so good.
We don't know that.
Although we don't know that. Secondly, another question I'd like to ask, is anyone here actively caring for a loved one who is aging? Actively, oh boy, the majority. And those could be your parents, your aunts, your uncles, grandparents, your friends. Before we go any further, I'd like to thank you, to those who are caregivers, very much for your commitment of your time, of your resources, of your energy, and of your love, because it is very, very, very much appreciated. Anybody here who is being cared for? Anybody being cared for? A couple? Thank you, too, for being here tonight, because to be frank, it takes real guts to age well in our youth-obsessed culture. Thank you for your patience, for your flexibility, and thank you for allowing us to serve you and let us know if we get things wrong, and occasionally if we get things right. Finally, any baby boomers out there? Any baby boomers? Me too, me too. For those who aren't sure, baby boomers are those in the generation born between 1946 and 1964. Now, I should tell you, this talk was made specifically for baby boomers. And why did we do that? Because statistically, we are the demographic who's going to be caring both for our aging parents and also caring for our coming-of-age children. Sometimes it's hard to tell who is more of a hassle to take care of. In addition, most of us are working full-time, and of course, most of us have to look fabulous. And so all of that, of course, puts a very big difficulty on us boomers, which often leads us as a group to feel a little bit tired. Anybody in the audience feeling a little tired? Maybe at times any of us feel a little short-tempered. Do you ever lose your temper? No, the audience, nobody raised their hands for that. A show of hands also, who is currently barely hanging on, really at wit's end? Well, if that's you, you've come to the right place, because this talk is definitely for you. Now, I know this because as I was preparing for this talk, I researched through our Bible, the AARP magazine, and this is the AARP magazine from January of 2014. And I found, frankly, all the answers to what ails us in this magazine. Especially, I should point out, one, how the boomers changed America, although it was interesting, it originally states how the boomers ruined everything. And in it, it goes on to say, yes, we're spoiled rotten, we're self-absorbed, and it seems like we never shut up, okay? But for the boomers, we've made a better world for everyone else, and you're welcome. When I was coming up with the title for this topic, Attention Boomers, Helping for Caring for Our Aging Parents, it happened to occur approximately 2 months ago as the 2014 Academy Awards nominations had just come out. Have any of you seen the Academy Awards that happened just a few days ago? Any of you? Oh, many of you did. So for just a second, I've got to share with you, as I was coming up with the title, I wanted it to be catchy, a little bit punchy, maybe a little Hollywood, a little sexy. So I actually had some other ideas to come up besides what you ended up seeing. So if you give me a minute, let me share with you what some of my original thoughts were. The first was ethics in healthcare, attention boomers. Do you sometimes feel as if you're drifting aimlessly in space? How about this one? Attention boomers. Does your cell phone ring and first it's your parents, second it's your kids, and finally it's your boss, and you feel like you've always been doing the American hustle? The next one, baby boomers, do you ever fantasize about sending your loved ones to visit family in Nebraska? Even if you don't have family in Nebraska. I thought about this one. How about springing for an all-expense vacation cruise to exotic places with Captain Phillips? That was a little sick. I apologize for that. I came up with one. Baby boomers, do you ever dream about calling up the Dallas Buyers Club and purchasing whatever it is they're selling and using it yourself? Okay, enough of these bad puns. I'm sorry about that, although, frankly, I've got just two more. The first is your previously kind, loving, and doting father turning in to the Wolf of Main Street? And also to you caregivers, do you affectionately describe forcing your elderly mother to take her 19 separate prescription medicines, Pillamina? And finally, the one I chose not to do, how many of you now feel like you describe your life as 12 years a slave? You could all see the choices that I had, but I stuck with the original title, and I did so for a very specific reason, because I thought it was the most accurate, providing you, our audience, and more importantly, our community, with our loved ones and your kids, with practical advice on how to lovingly and responsibly care for our aging and deserving parents. So again, I'd like to thank you all for coming tonight, and join me in thanking Community Memorial Health Systems, its Board of Trustees, its administration, for hosting and supporting tonight's event. Thank you very much. Thank you also to the many community partners who are outside, hopefully coming inside now, who have graciously joined us and who provide a wide range of assistance and information in caring for older adults and the needs of us, their caregivers. I'd also like to recognize several people by name. Mr. Mike Ellenson, who you met previously, who's the Vice President of Marketing Development, and Miss Mary McCormick, Mary, who's somewhere around here, I don't see her right now, who's the Manager of Marketing, both of whom were indispensable for putting on tonight's event. I'd also like to thank Rick Ruffinelli and Zestnet and Hugo, who's sitting behind the curtain over there, and all the crew who's helped to put on tonight's event. And now it truly is my great pleasure to introduce tonight's truly great keynote speakers. As has been our custom in the other two sessions we've had, each speaker will have approximately 15 or so minutes to present their prepared remarks. Following their presentations, we will have adequate time to pose questions to our speakers and to our community partners. If you can think of a question, please write it down on an index card, which you have right in front of you, and pass it along to one of our ushers who's walking around. So let's go ahead and begin. Our first speaker tonight is my dear friend, Miss Bonnie Tsuburaya. Bonnie was born in Brooklyn, New York, and she received her bachelor's degree at University of California at Santa Barbara in Law and Society. She received her master's degree in social work from UC Berkeley, a wonderful school, and go Bears. I graduated from UC Berkeley, as you may not have known. For 10 years, Bonnie worked in the probation department, which gave her a significant amount of leg up in helping boomers care for their aging parents. And then for the past 20 years, she has been a medical social worker at Community Memorial Hospital. Currently, Bonnie has risen through the ranks from social worker in the intensive care unit to every unit in the hospital, and she now deservedly is the Director of Social Services, Case Management, and Palliative Care at Community Memorial Health Systems. Bonnie is married, has 1 daughter, 2 stepsons, and 5 grandchildren. In her spare time, Bonnie told me she works. However, she occasionally finds time to hike, camp at the beach, and travel. Ladies and gentlemen, it's my deep pleasure to welcome my good friend, Bonnie Tsuburaya.
Okay, so let me just say, wow. It is so impressive to see this room full, and it is my absolute pleasure to be here, and I thank you for letting me share with you tonight. I know that Jim offered his appreciation for you all being here, but I think before I start, it's really deserving to just take a moment to applaud all of you here in this room. I really, I think for taking the time to come and to be interested in planning for your future and what the potential impact is as you age or your loved ones age, and what your resources are to help you manage that. So I really applaud you for being here tonight. Where do you start with caregiving? I mean, Jim covered the whole movie season, and really, where do you start? It's a big, big topic, and it has many facets. And so I'd really like to sort of pare down in the 15 minutes we have together here and talk about planning and communication. Because really every day at the hospital we see what is really just such a paralyzing impact on patients and families as they attempt to put plans together for caregiving in the midst of a hospitalization and often a crisis. So it is my sincere hope that tonight's overview, along with our partner agencies, helps you begin to prepare for whatever caregiving role you may be taking on, and gives you some useful and usable information and services. Because, as Rosalind Carter so succinctly states, there's really only 4 kinds of people here in the world, and I think they're representative in this room. Those that have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. Okay, so welcome you all tonight. Okay, so I'd like to start by just going through some of the challenges that we certainly face as individuals, but as a community as well. And I think the first, and many of you probably already know this, is that hospital stays are getting shorter. And so as care transfers to the community for continued convalescence and rehab, we have a much greater reliance on community care providers. So we wanted to introduce you to many of them here tonight and get to know them. And the idea that as we age, we are really moving away from what is one episode of care in a hospital to managing an illness over time is a theme that we'll return to through tonight's remarks. And as we plan to manage those chronic illnesses, we really have to consider community providers, both medical and non-medical. So another challenge I really want to alert you to is the changing demographic, both here in California and in the nation at large. We are aging all across the nation, and as you can see, by 2030, the age group 60 to 64 will increase 32%. But what is really staggering to me is the 85-plus population in California will grow by 310% by 2050. That's a staggering number to me. And when we consider how we age and the chronic disease that we may carry with us as we age, the issue and addressing decline in function, all really adds up to a greater need for more health care and supportive services. So, busy slide here, but I think It's an important slide for you to read through because it's a great summary for what we're facing here in California. And as you can see, there are the combination of certainly just a growing population and then a growing aging demographic really conspire to tax the California infrastructure. And so some of the services that we rely upon are going to be stressed severely. And I think it's important to bring these to light. So at the risk of overwhelming you 2 minutes in here or completely depressing you, let me just say that information is power. And I think the opportunity to have an idea of what environment you're operating in and consider the impact it's going to have on your family or your loved ones puts you in the unique ability to really plan and prepare. Okay, so we all know we need to plan and prepare, so where do we start? So I think we start very clearly by having conversations, okay? Communication is absolutely key, and I would urge you to begin your conversations with your elders or family members now. The following elements that we have here are really just suggested topics for you to jump off into, and we'll cover each of these tonight. But even more importantly, I think they represent an opportunity for you to work in partnership with your loved one. And again, not at a point of crisis or contention, but to join together in some planning, hopefully ahead of time. Some points that I'd like to stress as you consider having these conversations with your family members, that again, they should begin early and before the point of need. Conversations as opposed to one, and revisited over time as things change. When possible, and for some of you it's not possible, I would urge you to proceed at the pace of your loved one in planning for their life. They may or may not be ready to speak completely to all of these issues. So I urge you to remember that this is a process, and please don't give up. Keep trying. And remember that there's help for you, much of it here tonight, okay? So let's go through these quickly one by one. And this is really sort of a survey overview to get you started. And I hope that we have the opportunity to speak in more in depth in the future on these issues. So really the first topic is to gather your information around medical history and begin to understand insurance and how this whole care thing really works. So when you start by learning your loved one's health condition, it really gives you the opportunity to meet with our care providers and begin to see what the impact of this illness is for your loved one as they age and as a chronic disease can progress. So it's really important to know what the plan of care is. How are they treating this illness? What are the medicines that are prescribed to treat that illness? And what's the impact? How does that chronic disease, how does that heart failure, how does that diabetes affect your loved one now and 6 months from now and a year from now? And these are hugely important conversations to have with care providers. When we move into the arena of insurance, learning each insurance policy sounds almost trite, but we are continually amazed by the people that we meet in the hospital that really don't know what their policy covers. And in some ways, I really feel for them, because how many of you have tried to read an insurance policy? Okay. Okay, so you all know what I'm talking about here. And I think that at the point of stress and illness, it becomes a very overwhelming task. So I would start early and wade through and understand, paying particular attention to benefits, but even more important to limitations. Okay? Because often those aren't discovered until you need to access a benefit and find it's a limitation. Okay? Understand co-pays and insurance coverage. All of you have heard of the donut hole? Have you all heard of the donut hole? Does anybody understand one bit of logic that went behind planning for the donut hole? Okay, me neither. And so they become incredibly complex and convoluted sorts of coverage. So important to start exploring now and seeking help when you have questions. There is help out there. For those of you that are comfortable on the internet, Medicare.gov has a wonderful tool for comparing insurance plans in your area. We have great representation here tonight with the Area Agency on Aging, who sponsors a HICAP program, which is a health insurance counseling and advocacy program. That is a free service to residents in Ventura County. Please inquire and make use. You can really learn some useful information. So again, please remember that some elders may be reluctant to involve you in these discussions or in these inquiries. So whenever possible, I would really invite and encourage you to begin asking and not telling, and try to move at that individual's pace if at all possible. So legal and financial considerations, really you're on a document hunt, and if these documents haven't been completed, you should consider having them done. So as you can see, we start with really some of the more basic kinds of documents that you all would assume you'd need to know where they are and what's in them. But as we move down the list a little bit, there are some subtleties around some of these documents that I would urge you to pay attention to. As you identify bank accounts for your loved one, it's really important to know if they've given access, and to have that discussion around who should have access and what type of access. It is very important to work with a particular bank, because I can tell you that many banks will not take a general power of attorney. They want their power of attorney done. These things take time. They're very difficult to get done in the context of a hospitalization or need, so they're worth paying attention to ahead of time. Advanced healthcare directives, hugely important document, and certainly more attention paid in the next installment of this series. But if somebody's gone to the trouble of completing one, you should find it. And if you are that agent, you should have a copy with you at all times. So when we move into some financial considerations in preparing, this one gets overlooked all the time, and it's ridiculously simple, but we all forget about it. So how many of you that are caregivers know the bills that your loved one is required to pay, when and to whom? How many know that? Whoa, that's good. That's very good. We see this as a fallout and a point of stress repeatedly when patients are in the hospital. So I would encourage you to get those documents together. The list continues. I won't read through these bit by bit. Just urge you to consider that many of these documents are required when you apply for services or benefits. VA benefits obviously are going to require military paperwork. So it's a good idea to know where these documents are. Okay. Oh, I'm sorry, they split my slides here and I'm a little out of sync. So here's the last page with more documents for you to consider and pull together. Okay, so this becomes a really important topic when we talk about housing, because housing is so tied to quality and the identity of people. People spend their entire lives in their home, in a particular home, and they build memories and an identity there that really needs to be respected. And so as you start to talk with family members about how housing may need to change over time, it's so important that you've done your homework and you know what the different options are, so that you really can have an educated discussion with that family member. I'd urge you also to go visit these facilities with your loved one, and again, before the point of need, so that when you have the discussions, you have some frame of reference for what you're discussing. For those of you that are interested in learning more about nursing homes, we have some of the other types of living situations represented here tonight, but in particular the nursing home, because I think there's so much confusion around what that is and what roles they can play, both short-term and long-term. On your card there is the notification of the panel presentation that'll be taking place March 18th. And I think really beneficial with representation from these nursing homes and the ombudsman, so some advocacy there as well. And I'd urge you to consider it's a very interesting time in our lives, and I think many people are starting to respond to some of this changing demographic, and they're getting very creative in the resources that they are creating to plan for their aging. So the concept of shared living and roommates is resurging and growing in popularity. But there's a new one that I came upon when I was getting these slides together, and it's the medical cottage. Does anybody know what a medical cottage is? Okay, this one's new, and it may not be for everybody, but it literally is a prefab pod that can be dropped in your yard that is completely outfitted as a living environment. Bedroom, small kitchen, bathroom, and complete with monitoring capabilities if you so wish. So, you know, this may not be your choice for living, but I think it represents really so much creativity that's going on in thinking about these things and alternatives. So that was an interesting one. I think the next element for discussion and planning is really assembling your team. And I can't stress enough that caregiving is not a one-person endeavor. It really does take a village, and it takes a team. And I hope that you have resources at your disposal, and if there are gaps in your resources, that you know about the services in the community. But some things to note as you assemble that team or team of support for caregiving. Getting in sync with family members and siblings is huge here. And I think it's a huge issue for many of us because caregiving can cause a strain in and of itself. And it can often bring up old sibling rivalries, childhood dynamics can reemerge. And I think it's important that you know that going in, and you prepare for that as you try to create some collaboration with family members. If you can focus on your loved one and achieve those coordinated efforts, it just results in better care. I mean, there's nothing else to say about it. And while this may not always be possible for you, I urge you to keep focus on that loved one, because the time and energy that gets spent in disagreement, and believe me, we see this disagreement in the hospital every day, is time that really could be spent caring for or advocating for your loved one. So I think before you even attempt caregiving, putting some effort and energy into knowing who is available to coordinate with you and working on those relationships is very important. The other thing, and you're doing this tonight, you're here to learn the resources in this community, many of whom you may have had a chance to meet already with regard to home health, private duty care, adult day health, community-based agencies. We have a great resource in the Camarillo Healthcare District, which is not restricted to Camarillo, by the way. And they have very robust programming for both caregiving and senior services in general. Area Agency on Aging, another wonderful public resource that I would urge you to learn about. And certainly private care managers for those of you that have relatives that live in other cities that you're concerned about and may need some help in caring for. So end-of-life considerations and advanced care planning. This is a hugely important topic, and it will be discussed really in great detail April 16th. But I'd really like to talk with you. I think it deserves emphasis, and talk and give a few reasons why the discussion is hard, and also why the discussion is so important. So I think if you consider that at the turn of the 19th century, 50% of children under the age of 12 died, and the average age expectancy was 48 years. So death was really a part of every household, okay? as early as 40 years ago, people almost certainly died from heart attack, stroke, cancer. And as medical and technological advances have extended lives, they've ironically shielded entire generations from directly witnessing death. And I think the result of that is that many of us are ill-prepared to address end of life or initiate discussions. It's just not a comfortable process. And really, societies that are shielded from death run the risk of fear, denial, and perpetuating the notion that death is somehow optional. And I think for any of you that have been faced with an actual imminent death, really wish with all your hearts it could be optional, right? So these are very human emotions here. And I think we need to recognize where we are in our preparation or easiness or uneasiness to have these conversations. So a couple of reasons now, I think, why this conversation is so important. Living longer now means managing chronic illness. So the illnesses that used to take our lives are now treatable illnesses, and we carry them with us as we age. And along with that comes a natural functional decline as we get older. And it begins to beg the question of quality. So as medical advances really allow for quantity, quality is a very personal and individual determination. And here's the thing, you really won't know what's most important to your loved one unless you ask them, okay? If you deny or you avoid this discussion of end of life, it really robs your loved one of the opportunity to prepare and to make choices about how they want to live, really, because this is about living before they die, okay? So I think some other things to consider here is that being part of and an advocate for what is important to your loved one is really a true gift that you give them, and one that you carry with you long after they're gone. And I can tell you, when we see family members who feel like they've advocated for their loved ones at the end of their life in the hospital, it brings a sense of peace, and to know that you were able to do something. You can't, you know, you're not God, and you can't extend life when that's not possible, but this is a gift that you absolutely can give. And please consider that avoiding or delaying discussions like this really robs you of the opportunity to share in and honor your loved one's wishes. So there are significant reasons why it's worth facing the fear and discomfort. And I really want to alert you to the fact that there are services that really have been developed as we recognize the need to confront these kinds of issues and discussions. And one wonderful service is palliative care. And you will find palliative care service operating in the acute hospital, and you will also find it in the community. And I think, you know, these folks can be so helpful at helping you begin to address these questions and issues. So I'd really like to end tonight, my comments tonight, with the last element, and that being self-care. And while it's last on the list, it certainly is not last in importance. And so I just invite you to consider that it is truly difficult to adequately care for someone else if you haven't cared for yourself as well. And I want to leave you tonight, again, this is the first 3 excerpts of the Caregivers Bill of Rights. And again, we split these slides so that you could see them. It would have been very busy if we added them all. But I do have the entire Bill of Rights for caregivers, but I think this will certainly get you started. And I'd like you to just take a moment to read these, because they are so, so important. So the first one, I have the right to take care of myself. And this is not an act of selfishness. It will give me the capability of taking better care of my loved one. I have the right to seek help from others, even though my loved one may object, and I recognize the limits of my own endurance and strength. I have the right to maintain facets of my own life that do not include the person I care for, just as I would if he or she were healthy. I know that I do everything that I reasonably can for this person, and I have the right to do some things just for myself. And so I hope that you carry these thoughts with you as you proceed in your journey in defining what caregiving is for you. Thank you so much for your time and attention.
You know, I've had the wonderful opportunity of hosting a number of these events, and I can just tell you, no one gave a better overview of a more complex, emotional, and difficult topic than Bonnie just did. Could we please give it up for Bonnie? And let us also hope that Bonnie takes a little more time hiking and camping at the beach and self-care for herself. It is my real honor to introduce our second keynote speaker, Dr. Lanyard Dial. Dr. Dial was born in Taylorville, Illinois. Lanyard, is that near Nebraska? Is that
Nearer than this.
Neighbor, okay, closer than this. He received his bachelor's degree from the University of California at Irvine and his medical degree from the very prestigious Washington University in St. Louis, Missouri. Lanyard completed his residency at the Ventura County Medical Center, where we were co-workers for a number of years, and he is currently triple boarded and certified in 3 different areas. Now, I should share with you for a second, being boarded in one area of medicine is difficult. Being boarded in 2 areas of medicine is even more difficult, and being boarded in 3 areas of medicine is unheard of. So let me share with you, Lanyard certified in family medicine, geriatrics, and palliative and hospice medicine. Those are really an accomplishment and something in and of itself worthy of great praise. Dr. Dial was on the faculty of the Ventura County Medical Center, and he rose through the ranks to be residency director of the Family Medicine Residency Program from 1987 till 2001. He then assumed an even more demanding job as medical director of the entire Ventura County Medical Center from 2001 to 2006, and is currently the president, CEO, and medical director of Livingston Memorial Visiting Nurses Association. Lanyard is married to his beautiful doctor wife, Mary. Is Mary here?
No, she's working.
Mary is working. Mary is working and has one beautiful daughter, Hannah. In his free time, Dr. Dial loves to golf, and I understand he's quite a good golfer. Ladies and gentlemen, please help me welcome my dear friend, Dr. Lanyard Dial.
Bonnie is amazing, and what Bonnie covered in the time frame she had, I had the opportunity to see her slides ahead, and I said, well, where do I and how do I help and add to this? And I'm going to come at it as only way I can, is that I'm a physician. And I've taken care of a number of people who I would call senior and geriatric, and I've also taught countless numbers of classes on how to help take care of seniors, both for physicians and for non-physicians in community-based classes. Camarillo Healthcare District does have an excellent caregiver series. It's a series of programs about how to be a caregiver. I helped them develop that program, and I teach 2 sections of it every session. So it's a delight for me to have a new audience of some of you who haven't met me or I haven't met you to teach a little bit too. I will start by saying at first, I'm going to sound a little pessimistic. I'm the eternal optimist, if you know me. I honestly believe in brighter days and times in the next tomorrow and all those great things. But you have to understand, in order to understand geriatrics and care of seniors, you have to understand what's going on from my perspective as a physician. Aging is a total mystery in science. We have no idea exactly what causes this. But anything that lives ages. whether it's a flower, a tree, a squirrel, an ant, a human being. We're born, we come from a seed, we grow, and we wither, and we die. Whatever has lived dies. And the process of aging is a process of loss of ability and function. You are your best in your teenage and early 20s, and it's downhill from then. You will continue, sorry. No, you don't have to leave, Jim. You can, no. You will continue throughout your life to find that each part of your body and mind starts to lose things. You will lose mobility of joints, you will lose brain cells, you will lose kidney cells. Every single organ ages and loses function. You will decline until at a point you will die. Inevitable, it will happen. Couple that with the most important, from a physician perspective, second issue, and that is that diseases occur. And our job is to treat and find those diseases so that as they're occurring, you are affected by them as little as possible. So the two together, the aging process and those diseases, are what face all of our futures and our current lives and our loved ones who are aging ahead of us lives. And what will happen is that those two will cause us to lose the abilities that we have. Medicine in the United States, in my opinion, far exceeds medicine in any other country in its ability to do things. But my pessimistic side is it's broken. We have a disease-oriented system and not a health and person-oriented system. What Bonnie went through and talked about has a lot of details in there that encourage you to understand as best as you can, because the system is broken and you have to understand it, otherwise you can't navigate it. We have a system evolved when we started learning all the science. After World War II is sort of my time frame, when we got antibiotics, we got vaccines, we got good public health, and we started learning all we could about medical care. We've evolved into a very disease-oriented system, a system that says, you have this illness, we fix it, and that's it. So all of the focus in the United States has been focused to hospitals and doctors. Hospitals and doctors are an essential part of a disease-focused system. The payment scheme for the entire system is set up to say we pay the hospitals to encourage them to get you home quickly, and we pay doctors for 15-minute visits. That does not work in a chronic disease age community. We are in the midst, in the last couple of years, and will continue over the next probably 30 years to change that system. But it needs to be changed before it'll work correctly, and we're all stuck here now. And we're all stuck trying to navigate a very complex, broken system to figure out how do we best get through this. That's my pessimistic part. Let me move to my optimistic part. So let me give you some suggestions besides what I absolutely agree with Bonnie and searching for those answers and having those conversations. One that I think is essential for us to understand is we have been sold by our system that we have now that medicines will fix us. Drugs will fix us, not healthcare, drugs. And we are taking way, way too many medications. The side effect profiles of most medicines have not been adequately studied with the complex mixture of all the chronic diseases and all the other medicines. There's no question in the field of geriatric medicine, there are sections and lectures on and on about the problems we have with pills and medications. I was told when I very first got into this field by an esteemed geriatric physician in the country that if I kept a list of all the medicines I've started and a list of all the medicines I've stopped, I would be a better geriatric doctor if my stopped list was longer than my started list. So I encourage all patients and all loved ones of patients to figure out how to help themselves or their loved ones get off many of the medicines they're on. There are simple ways to do it. It's not complex. You take all the medicines in a bag. You go into your loved family doctor, and you should all have a loved family doctor. You set the medicines down and you say, today before I leave, we're going to stop one. I can randomly pick it out, and that'll be the one. You could randomly pick it out, or let's have a conversation about what might be the most appropriate one to try me off of for the next month. I will come back. I will see you again. I will bring the medicines again, but I want to stop one of these. Try that month after month, and you will eventually find that you can reduce an awful lot of the number of medicines you're on. So medicines, big deal to me. 2, I have what has been touted as snake oil potion thought. And that is, I can get you one treatment that will actually improve your memory, improve your joints, improve your immune system, make you feel better, hands down, no question. And that's exercise. Anything you can do or encouraging your loved one to do to stay active, to develop a good exercise routine will make them better. It's cheaper than most of the drugs we prescribe. It's easier if you believe it and get there. Now, I'm not saying everyone has to run miles or get on treadmills, but you need a good exercise program. That exercise program should definitely include flexibility, balance kind of exercises as you age. So a good yoga, tai chi, some kind of organized, I can figure out in space where my body is and control that is incredibly helpful as you age. So get rid of medicines and make sure that you start a good exercise program. Encourage that in the people you're caring for. Hands down, that will help. What Bonnie touched on, which is my life, is I spend most of my time now in hospice care and palliative care. And the reason I do that is that I have, through my time taking care of seniors, recognized that that's an expertise I have and a mission and a drive I have, but also it's an area that's been neglected way too long in our society. And I have felt like if I could help people get over this hump, it would be huge. And the issue to me is that we all likely will age to a point where we will start to have significant problems. We may die before that. You may get a terrible pneumonia and die. You may get hit on Main Street tonight and die. But most of us are going to die a death that we see coming in a progression of illness and a progression of loss of function. There has to be a point at which we make the decision that life at this point is not what I want it to be. For more than half of us, it's highly likely that we will develop a terrible dementing illness. An illness that takes our brain to a place we don't want to see it go. Many of you are providing care to people with bad dementia. It's probably the current 2014 scourge of our society. Dementing illnesses are an enormous problem. I usually, and I'll do it just so you know that I've done it here too, ask an audience, how many of you would like the last 2 years of your life to be that you're in a home cared for by somebody else because your family can't do it, and during those 2 years, you're not able to control your urine or your stool, you can't feed yourself, you can't recognize your family. When your family comes in, they're embarrassed to be there and don't really want the kids to see you because they don't recognize you much anymore because you don't know who they are and you're drooling out of your mouth. And is that the last 2 years you want? 1 million people today are living like that. Why? We have not faced the decisions we need to be making as a society, as people, that says allowing that person to die is better than that existence. And hopefully, when we get that kind of illness, we will have the say that says, I didn't raise my hand when I heard it there and I don't want it now. Never let me get to that place. And I can do that, not by giving you a pill that kills you, but by making better medical decisions about how your life is going. Should you or should you not get a treatment for this infection? Should you or should you not get a feeding tube that would continue your? Should you or should you not have that bowel obstruction surgically repaired? There's so many decisions that need to be made that we have the ability to say, medicine can do this, but should it? Hopefully in my short time, I've piqued your curiosity about medical care in seniors and what's important. Chronic diseases on top of aging, stopping medicines, exercising more, dealing with the tough issues of as we age, how do we help ourselves die at a point that is appropriate for who we are? We're not going to live endlessly. How do you want your last years to be? How do you want your loved ones' last years to be? And how do you make the decisions to help those go the way you want them for yourselves and the way you want to have them for your loved ones? I'm going to end. Jim has some questions. You have some questions. Thank you so much for attending this tonight.
Yeah, I have two things to say. One is certainly the more important. Please, ladies and gentlemen, you have to realize what a resource Lanyard Dial is to this community and to those of us who have had the opportunity for my entire career to work with him and to give a presentation like this, which really does a tremendous service of having someone who's respected in the medical community speak honestly and bluntly about what it is that we're all looking at as we age, not to depress us, but to empower us with information and to provide that level of dignity which allows all of us to live our lives in the fullest. So again, Lanyard, thank you so much for that presentation. I should also say I've been moderating for a while, and this is the first time I had to leave. I just have to take a little break in the action here and explain to you that this is almost art imitating life, or life imitating art. 4 days ago, my older brother, who lives in North Carolina, in Raleigh, North Carolina, called me and told me that my elderly mother was dying, and that even though I was preparing for this event for tonight, he was afraid I wouldn't make getting to see her. So over this past weekend, literally last Friday, I flew out to Raleigh, North Carolina, before every airport closed on the eastern seaboard, flew in there and was fortunate to see both my older brother and my younger sister, and frankly say goodbye to my mom, who's 90 years old and who is in a nursing home dying of dementia comfortably. And I can tell you that it was a incredibly profound experience to see her, not just as a physician who cares for people at the end of life, which I did and was able to, connect with her on a very spiritual and in a very personal way, but also to interact with my older brother and my younger sister. And when you think about dignity of people at the end of life, as both Bonnie and Lanyard alluded to, it's not just the person in the bed, but it's the family who actually survives. And the legacy of my mom of 90 years, bringing her siblings together. My sister lives in Denver, I live in Ventura, my brother lives in Raleigh. Coming together over one phone call that my brother made was so profound to all of us that really, again, reinforced this notion of what it means to be someone taking care of people you age and also taking care of your people yourself. So again, I wanted to share that with you as way of saying I'm sorry for running out, having a cold, which I picked up on the flight coming home in 12-degree weather in Charlotte yesterday. So I'm sorry for that. What I would like to do, thank you. Thank you very much. What I would like to do is ask if any of you have any questions, if you would please write them down. A couple of our members of our Community Memorial Hospital family will come and pick them up, and we can share them over the next 10 to 15 minutes with Bonnie and with Lanyard and with some of our other community partners. But let me go ahead and ask some of the questions that have occurred not infrequently in my own practice. So again, this is to our panel and to our guests in the audience. And the question is this: Mom lives alone in our family home after Dad has died. It's too big a house for her, but she wants to stay. My older brother says, no, she needs to be in a more protected environment. I think it's okay, but I really do fear she might injure herself being alone, and I worry about her safety. Neither of us live close to her. What should we do? Bonnie?
Okay, so we just went through some slides, and I know it was just an overview for you folks, but let me ask you all, what do you do? Anybody have any suggestions?
Ask her.
I'm sorry?
Ask the patient.
Yes, thank you. I think that the starting point is to have that discussion with your mom that says, tell me what's important to you about staying in this house, and listen. And I think, we often employ I'll give you a social work secret, and we really call it social work karate. And it is going with the flow and the energy of the individual that you're working with. And so I think oftentimes what happens with children who feel that they need to exert care for their elders is that they attempt to take over or take control, and a power struggle ensues. And so my suggestion, if at all possible, and I know there are times when this is not possible, but whenever possible, I think you ask and you don't tell. And you try to find out what's important to your mom, because it may be very different than what you're thinking. And I think you try to go with that energy, and that opens the door to be able to ask the questions, well, Mom, what if? What if you reached a point where it wasn't okay to be here by yourself? How would you want to handle that? And I think it's those kinds of dialogues that get you where you want to be. Now, that helps people who have the time to have those dialogues, I understand. But that would be my general answer.
The need of an individual to have extra care or support wherever they're living, or removing them from that environment and putting them somewhere else by any insurance company or any Medicare or Medicaid or any system we've designed, it doesn't care about that, because they consider all of that to be non-medical care. That is in your bailiwick because you've paid for the house through your lives and you've paid for your food, and so if you need more help now, no one is going to help you pay for that. So don't look to Medicare or insurance plans to help you with the finances of dealing with that issue. I totally agree with Bonnie that the decision needs to be a discussion with the individual, and that the family needs to accept that individual's decisions about what they want. And I analogize it a lot to when we're all growing up and you're trying to raise a teenager, you have to realize that you can say and put all the restrictions you want, but it ain't going to happen. And that individual is going to make their own bad choices and have to do that. And we, as the kids with our parents, have to recognize they're going to make bad choices. That is okay, because that's the choice they need to make. They're an independent person. Now, if they're demented, if they have a brain that isn't working and they're making bad choices, then you have a responsibility to step in and help protect that situation. But if they're intact cognitively, if they have the ability to make decisions, and their decision is a bad decision, that doesn't mean you have the right to step in and take it away. And so you have to fight a little bit your own angst about, I want to do this and I think this would be the right thing, but mom would say, no, I'm staying here, and yes, I am going to drive, and that you have no say on that, thank you very much. And respect that. And then be there and ready to, like you did when you were raising your kids, pick them up and help them when they do get in a car wreck or something bad happens, and not go, I told you so, you should have done. No, fine, I'll help you through this and we'll get through this, because that's how you need to respect your parents when they raised you and did their best to do that. So,
You know, in this brings us back a few years, but when Lanyard and I were both in our residency back in the 80s, our residency director, Dr. David Feiner, had a quote on his desk, which I never quite understood, but I always thought was profound. It was one of those things that you thought was really meaningful, but you didn't know what it meant, until actually when Lanyard was speaking. And on his quote it said, "Don't just do something, stand there." Okay. And I think what Bonnie and Lanyard just alluded to, and what the gentleman in the front row said, and I think what an approach to this answer, which I would consider the correct approach, is not to run in and do something, but to stand there and to act with a little bit of humility, a little bit of humor, and a little bit of understanding that these are difficult choices for everyone, and to respect the choices of the individual who will be making that choice. And rather than run in and say, this is what you have to do because of whatever reason, to take a step back and realize that people, even at the end of their life, one of the definitions of dignity is to allow them to live the life that they are living. Which then leads us to the second question that was asked, which is this: my father was always a reckless and speedy driver, but now I worry that he's completely unsafe. I won't let my children drive with him, yet he insists on driving everywhere himself. What should I do? Lanyard?
Reflecting back to my previous thing, if he's cognitively intact, so his brain is working, and you can ask him questions around his ability to understand red lights and green lights and octagonal signs that have S, T, and O, and P on them, and so you believe that he can understand those things, but you're worried that he's becoming more frail and can't drive. You should take a step back and accept that he is cognitively intact, and you have no right to stop that. If you wanted to intervene, well, let me go the other way. If he's not cognitively intact, then you have to intervene. If he's not capable of making good decisions, you have to step in. If he is capable of making good decisions, then the only thing you can do is turn it back to the DMV to let them do testing to see if they will give them a license. Now, I had this conversation with one of my early patients in this career of mine, and she politely looked at me and said, "Oh, honey, I know you're worried about that, and you don't have to worry because I don't have a license either." Which just showed to me, you know, it isn't a licensing issue necessarily. It isn't I have the ability to drive, and you're not going to take it away from me. And so I'm there just to pick up the pieces. You should know the statistics. The statistics really are that the driver is the injured person many, many more times than it is somebody else. The news loves to highlight the individual who's driven through the street fair in Santa Monica or through the buildings and all that. And I get that, but really when you look at the statistics, it's really the person. And that's what you have to allow to happen, otherwise you get in a huge fight. And again, if the person's not cognitively intact, then you have to get into that fight and you have to take away that right. But if the person can make reasonable decisions and wants to continue driving, you don't have much control there.
Bonnie,
My
do you have
turn?
any?
Okay.
Yeah.
So I hope that as we go through some of these scenarios, you can see the value in addressing these issues or beginning these discussions before the crisis starts, okay? So I can tell you with my own mother, who lives in Leisure World in Orange County, I went to visit her, and her neighbor promptly pulled me aside and said, "Your mother is hitting parked cars," okay? So, okay, so, you know, obviously the crisis was close. So I had to ask her again, not confront her, but ask her, "Mom, what do you want to do when you can't drive anymore? What do you want to do?" And I think you can structure your questions in a way almost like you did with your kids, where they're not totally open-ended. You know, "Johnny, do you want a shirt?" or "Johnny, do you want a blue shirt or a red shirt?" I mean, I think you can structure your questions, but asking that question was a bit disarming for her, and she said, "I hadn't thought about it." And we were able to then have a discussion that said, well, let's look at what it costs to maintain your car and pay for gas and pay for insurance, and how could we use that money to help provide transportation for you if you reach a point where you can't drive, so that she was able to make the decision, and we could support her in that decision. So if at all possible, do it now. If you know this is going to be an issue down the road, and it is for all of us, I think that's the question. It's preparing for, what will I do if I reach a point that I need this? I mean, I think these are questions we need to ask ourselves. What would I do? How would that feel for me? And I think you get some window into what they're facing and the decisions that they have to make. And I don't think there's any arguing with Dr. Dial's point that if capacity isn't there, then you have to take a more proactive role. But if it is, do it now. Have those discussions now.
Excellent. I should also mention, in our county, I'm unaware of any agency that independently evaluates elderly drivers to see how well they drive, independently of what you think or they think. However, I can tell you at Northridge Hospital in the San Fernando Valley, they have a program that's certified where they actually test elderly drivers and then rate them and tell them, yes, you do very well and we see no problem. Or in the case of my mother-in-law recently, gee, we love you so much and it would be such a shame to see you die in a car accident. And so therefore, we are failing you and you no longer can drive. Now, they did it in the most gentle, kind, loving way I have ever seen anything done in healthcare. I was absolutely not only amazed, but I could learn from what they did. They turned to a woman who had driven for 86 years and in a way explained to her why under no circumstances she should drive, because she's too wonderful a person to lose. How they did that was genius. I have never seen it before. My jaw dropped, and I thought that was among the most wonderful way of delivering bad news I had ever seen in my life. And to this day, she still says, well, I don't agree with them, but they were so nice. So again, I suspect over time, as this becomes a bigger issue, and that gray zone where they neither are completely dementing or that they're completely well, that there's this gray zone that we're really not sure. And my sense is that more places besides Northridge Hospital will start having those kind of facilities, which I would encourage in our county to have. But if you are stuck, it's not that far, it's about 45 minutes away, and they are as good as I've ever seen in telling people no. I wish they were there when my kids were growing up. So I have question number 3. Lanyard alluded to this very briefly, but I'm going to be slightly more specific. And this actually is a case of mine. My 94-year-old mother, who is in reasonably good health, she has some health problems, but nothing that are life-threatening at this point, was in the hospital for an acute illness. However, she said, you know something, Doc, I'm just too old, and I'm really sick of living. Let's just get this over with. Can't you do something to make this over with now? And the question is, what should we do? And her son was sitting there, and her daughter was sitting there, and they both got very agitated, and they both looked to me, and they both said, do something. And I said, you're in luck. I get to ask Lanyard and Bonnie. So Bonnie, a reasonably healthy 94-year-old with enough little things that were bothering her, but certainly not terminally ill, just says, I've had it. I'm done. I'm tired. I've outlived everybody. My life is fine. Just let me go. Now, what does that mean, and what should we do?
Okay, so again, if you were all listening to tonight's presentation, I want to ask you, what do we do? What's the first thing we do? I'm sorry? Speak up.
Have a conversation.
Have a conversation. There we go. Thank you. And the essence of that conversation is what? What do we ask this woman who makes this statement to us?
What are you saying? What?
Yeah, what do you want? That's exactly right. And there's a million ways to ask the question, what do you want? What's important to you? What's causing you pain and distress? I think, and to begin a discussion about why she feels the way she does, because we don't know, do we? And we don't know what she means by that statement. Is it a moment's frustration? Is it is there a dissatisfaction with a certain illness that she carries with her? We don't know. And so I don't think, none of this is magical, and in many ways it becomes very simple. And so much of it is around communication. And I think that when you arm yourself with information from which to have that communication, it becomes a much easier process. So again, I would encourage you to inquire and to not feel the need to have to take action. And that when you do feel the need to take action, to stop yourself. And again, it's another practice we engage in the hospital, that every time we feel the urge to tell somebody something because we're so darn smart and we know so much, that we stop and we ask a question instead. And I think that we learn so much more, and it's such a more respectful discourse. So I would ask.
Absolutely. No question. I want to know more about what this person's thinking. Let me throw just a few facts to help around this, though. What's the average life expectancy of a 94-year-old person in the United States today? How much longer, on the average, would that person be expected to live? And the answer is a little over a year. So her average life expectancy is a little over a year. Now, averages are averages. So, she could live for 2 months and she could live for 3 years. But in general, when you look at average life expectancy of an infant born today, it's going to be 80. People are going to live to be 80. But once you've reached 80, you have a longer average life expectancy now because you've already made it there, so you didn't die off earlier. And so once you reach 94, the average for your continued life is about another year and a half. And what is it during that year or year and a half that that person would want? And frequently, and my mom and dad were both in that scenario, they basically said, I never want to come back to the hospital. I never want to have to go to an emergency room. I want to be just kept comfortable and allowed to stay at home. You've just defined virtually the Medicare certified hospice benefit. That I want no more aggressive medical care in hospitals or emergency rooms. I want to be kept comfortable at home. So now where you're stuck is, do you have a terminal illness? And you could probably find some disease in her that you could say, if you didn't continue to treat this or this, you would likely die of it, and you would be eligible for the Medicare certified hospice benefit. So that's an option in all of that. The second statistic to think about and look at is that there are places in the United States, and a huge movement that medicine is probably on the other side of, for the most part, to have a physician-assisted suicide available in states that's legal. It's now legal today, I think still today, depending on what's happened in elections that are going on, in 5 states in the United States. Oregon, Washington led the charge. Oregon led the charge. Washington came soon thereafter. And now another smattering of states in the Midwest and in the middle, North Dakota kind of states, that have approved physician-assisted suicide, which means people can say, I'm done, and I want a pill to take my life. Now, the I'm done needs to really have a series of clear diagnoses and terminality to them. So as described, this lady wouldn't quite fit physician-assisted suicide. And in California, it's not legal. So she doesn't fit it in 2 parts. 1, she's in California, and 2, she really doesn't have a terminal illness. But I think what we're going to see as a nation over the next 10 years is a perpetuation of that concept further. And you're going to see a growth in the idea that it's acceptable to have a euthanasia process like we would for our animals. That an individual can say, I've had it and my diseases are such and I want out and I want a physician to help me do that. Personally, I happen to be opposed to that for a variety of reasons that I would be happy to talk over with anybody. But I do believe that that movement is gaining ground in the US and will pass law in most states and probably in California. And then we'll all be stuck with what are the criteria and how do you deal with this. And again, she does not have a diagnosis that would fit that. So her best option to me, after you discuss out what she's thinking, and what I heard her say through what Jim's little information was, I've had it, I don't want to be in a hospital anymore, I don't want treatment, I'm tired, my life as I see it is done. And then the best option for her is moving into hospice care and having her cared for at home and letting her die comfortably there without further hospitalizations and ER visits.
So I think I'd just like to clarify. I think as a nation we struggle with that very basic concept that just because it exists in science and technology, we have to make use of it. And so the first step in this progression, and I think as we have these conversations with our family, is recognizing and respecting that just because there's a treatment available doesn't mean it's right for you. And so really, you know, gosh, before you jump to wrap your mind around physician-assisted suicide, I think you have to first start with the idea that it's okay for you to choose what's appropriate for you in the form of medical treatment. And that's a loaded question in itself, because how the heck do you know, right? I mean, it's a technical decision, and a lot of people are intimidated by that. So I think ferreting those things out, but the first thing, as we age and for our own decision making as well as our loved ones, I think we have to come to terms with the fact that it's okay to make those decisions, and that just because there's a pill or just because there's a treatment doesn't mean we need it. And at 94, if I'm sitting in a hospital bed and I say I'm done, I think, you know, Dr. Dial's absolutely right, that it is okay to say, I don't want you to treat me with medicines anymore. I'm not interested in extending my life. help me improve the life I have right now, but don't help me extend it. I don't need that from you. And for children and the younger generations to be able to say, that's okay.
I heard a couple of people applauding. Just by a show of hands, would there be any interest? I happen to have some connections with the ethics committee at the hospital. Would there be an interest in, over the next 6 months or a year, having a discussion, which I personally would support, about physician-assisted suicide and euthanasia? Can I just have a show of hands if that would be quite a lot? Okay, good. Well, I will certainly pass that along to the powers that be, which is me, and ensure, because that's an important conversation that we need to have. And as Lanyard Dial said, people of very good conscience could disagree on that. And one of the things that I so respect of Community Memorial Health System in their ability for us through the Ethics Committee to put on these kinds of forums is not to pick subjects which are easy, but to pick subjects which are important, and to believe that the community at large has the opportunity and the ability to sit through and reflect upon difficult conversations over time. So that I will take into consideration and hopefully have that kind of program within the next year. We have time for only one more, thank you. That was my wife, I think. We have time for only one more question. I come from a large and close family who all agree on a care plan for Dad who has advanced cancer. However, our distant brother, who rarely sees him, says, quote, "We're all not quitters. Dad's a fighter, and we never give up. He has been harassing the doctors, the nurses, the family to, quote, do everything, and if we don't, he'll sue." What should we do with this brother who comes from out of town, who disagrees with Dad and everybody else, but who seems to be causing a fair amount of, how should I say this, distress?
Oh, you just fed me a big softball there.
This is a softball.
Yes.
Good.
Okay, so just to expound, just so you know, in California, there is no order of next of kin for medical decision making. And there is for other things, but not for medical decision making. So that if you have not completed an advanced directive or a post form, your spouse has no more standing than your sister or your brother and your distant brother. So, right. And I think this is a topic that's very near and dear to anyone who works in a hospital's heart or provides care in the community, because it is all too common and it is terrifically destructive. So the greatest gift that you can give your children, this group of children, is to complete an advanced healthcare directive, because it takes the argument away from the siblings and it focuses on the stated wishes, your stated wishes, so that we're not talking about sibling rivalries, we're not talking about power struggles, we're talking about paying attention to what Mom or Dad wrote, okay, and the instructions to the best of their ability to provide, that we have an obligation to follow. It is a huge gift that you give your children, and I can't tell you how many times we have family members absolutely paralyzed when they're asked to make medical decisions and they have no guide. And so this is a huge gift. We have free copies of these documents. We are happy to give them to anybody that comes into our office. We have a notary. We will notarize those documents for you free of charge. They are that important. And again, in executing a document like this, it is absolutely required that you appoint an agent. And in order for the agent to know what you want, you have to have what? A discussion, okay? So here we are back to communication again. So my answer to you is to have instructions and take away that sibling power struggle.
part of me would say, I hope that the person who has the cancer can talk to us and tell us what they want, and I would make sure that if they could, and they could communicate that the one son who's in disagreement is in a conversation with me, with Dad, about what Dad would want. If Dad can't speak or communicate what he wants, and has had an advance directive previously filled out where he's spelled out what he would like, then I think sitting with that, what I occasionally call the incoming biological from wherever they're coming from, having that conversation with them, with that document, so they can see what that is. And hopefully that person is not the durable power of attorney, but if they are, then they are the ones that the father has wanted to make the decisions, and now you are stuck, because that's the individual who has the legal right to sort of make those decisions. In doing seminars like this, I had a gentleman up front who said, my son won't talk to me about it, and he's my only son, so he's going to be my power of attorney. And I said, then you've got the wrong power of attorney. If your son won't talk to you, that's not the person you want to have making decisions for you. You want somebody else. So pick the durable power of attorney, empower them to make the decisions that you want them to make, and tie them up and tell them, you have to make these decisions for me. These are the decisions I want you to make, because it gets really hard when those decisions become their responsibility. And I've seen plenty of times where the statements have been, I don't want heroic things, and the doctor has said, yes, but this feeding tube isn't really heroic, it's simply a simple thing and we should really do it. And the power of attorney goes, well, I guess we should do it then, because it's just a simple thing. So it has to be very clear what you want as an individual, and you have to help your power of attorney understand that, which goes back to Bonnie's, you have to have a conversation again and again early on, make sure everybody's clear on it. So that's where I would go with this one.
So all of us, let's practice one word: communication. Communication. Before we conclude our speech, our program tonight, it's been our custom to allow both our guest speakers to have one last chance on a soapbox. So perhaps, if you wouldn't mind briefly, Lanyard, in reverse order, the soapbox is yours.
I guess I thought, and I will hearken back to what you started with, which was the Academy Awards. If you have not seen Pillow or Philomena, you should. An amazing geriatric movie about an individual woman and her life and what changed her life. And what you see in that, very similar to many other well-done geriatric movies, is how strong a senior person who has a good mind is, and how determined and what their life is like. And you will come to love Judi Dench and recognize what an amazing 80-plus-year-old woman she is. The beauty of growing older is seeing someone like her and recognizing how important it is that we learn and draw from someone like that. This growing older thing is hard, but it's an amazing thing. And our youth-oriented society has to see the value in a senior who is an amazing person. So.
Yeah, well said.
Bonnie?
I'm sorry I don't have a movie pick for you tonight, but I think really what all these remarks are, the summary of all this is that, with aging comes responsibility. So, it doesn't happen in a vacuum. It doesn't happen without involving others around you. And you have an absolute responsibility to reach out to those people that are important in your life. Whether you are receiving care or giving care, or you're giving care now and expect to receive care later, I think all of us really have to recognize that this is not optional. This is our responsibility to our family members, to our loved ones, to have these kinds of conversations. These answers don't just come magically, and it gets very confusing in this technological age that really masks death and the fact that we're going to die. And so I think if you take anything away, I hope it's that renewed sense of responsibility to be good to your family, to be good to the people that you care about, and have these communications. And do your homework, I think. There's great community agencies out there, and some are going to be just right for you, and some are not going to serve you well at all. But it's important that you know what they are and how they work. And again, in advance. And then you can actually have an informed discussion and not just a discussion. So I'll leave you with that.
Less medicines, more exercise.
Ladies and gentlemen, please again join me in thanking our two terrific keynote speakers, Mrs. Bonnie Tsuburaya and Dr. Lanyard Dial. Really, great job. Great job. Just as a few closing remarks, many of us come from traditions who consider it not just a virtue, but a commandment to honor our fathers and our mothers. Sometimes, as we have seen tonight, that's not so easy to do. I do hope tonight that we of the Ventura healthcare community, and I mean not just the community health system, but all of our partners who have been here, helped you develop a few more skills, make a few more steps closer to fulfilling that noble and achievable goal. To our aging parents who are here and to our loved ones, thank you for giving us the opportunity to be of service. And to those of you who can't read this, this is the greatest generation in World War II who are saying, come on, men, this is for our kids to live in a world of freedom and for our grandkids to grow up in a world where they can spend hours a day looking at cats on some sort of fantastic information machine, which I think is their computer. Finally, to the boomers and to all the others here in the audience who care for our aging families, let's all say together, thank you, and in fact, thank you very much. And let's give each other a round of applause. Friends, our next Ethics of Healthcare series will be held on Wednesday, April 16th. April 16th, also at 5:30, also here. Our program will correspond to our country's, our national celebration of National Healthcare Decisions Day. As a preview of coming attractions, at that event on April 16th, we will present equally compelling mix of topics, including, now get this, code blues, DNRs, feeding tubes, ventilators, brain death controversies, and last but not least, can we finally have an open conversation about end-of-life care and death panels? We picked these topics again, not because they are easy, they are not, but because they are important. So please join us again on Wednesday, April 16th, when the Community Memorial Health System Ethics Committee and the Internal Revenue Service prove once again that death and taxes create a wonderful way to spend 2 evenings in the middle of April. Again, thank you everyone for coming. Thank you to our expert panel, and good night.